Good afternoon and welcome to our General Surgery Lecture Series. I am Dr. Galit Hakim, Assistant Vice President of International Healthcare Partnerships and Insurance Development at Baptist Health International. It is my pleasure to welcome all of you to this informative presentation. I would like to extend warm greetings to our friends across Latin America, the Caribbean, and everyone joining us today. During this interactive presentation, you'll have the ability to ask questions via the Q&A feature located on the bottom of your screen. I will be the moderator for today's lecture. This afternoon, I have the distinct pleasure of introducing Dr. David Motola. His presentation is titled From Referral to Results, the Team-Based Approach to Obesity Care. Dr. David Motola is a general surgeon at Baptist Health. He is a board-certified and trained to manage a broad spectrum of surgical conditions affecting most areas of the body. He has expertise in bariatric and minimally invasive surgery and performs robotic surgery to address abdominal wall hernias, hiatal hernias, gallbladder disease, and other foregut issues. His clinical interest includes both medical and surgical weight loss. Dr. Motola earned his medical degree at New York Medical College in Valhalla. He then completed a 5-year general surgery residency and bariatric surgery fellowship at Orlando Regional Medical Center. During his fellowship, he was a general surgeon at Orlando Health South Seminole Hospital in Orlando and at Dr. Phillips Hospital in Orlando as well. Dr. Motola is a member of several professional organizations, including the American College of Surgeons and the American Society of Metabolic and Bariatric Surgery, among other nominations. He has conducted research in his specialty, published his work in medical journals, and presented in national and international symposiums. Please, let's give a warm welcome to Dr. David Motola. Dr. Motola, it is a phenomenal pleasure having you with us today. Welcome aboard. We are really, really excited for this new journey that you have chosen with us at Baptist. Welcome. You may go ahead and present your
Okay. Good afternoon, distinguished colleagues. Thank you very much, Dr. Hakim, for that warm introduction. As he said, I am Dr. David Motola. I'm a bariatric and general surgeon at Baptist Health. Today, I want to share how we can better manage obesity through a structured and team-based approach. This is what I call the 5 pillars of obesity care, including nutrition, exercise, mental health, medication, and surgery. I know many of you here today are practicing in Latin America, where obesity rates have been rising rather sharply. So let's talk about how we can tailor solutions to your patients and particular healthcare systems. As it pertains to this presentation, I have no financial disclosures.
Dr. Motola, before we continue, do you mind reloading the presentation because it appears that it is kind of minimized and I can see your notes?
Oh, okay. I will.
If you want, you can exit and upload again.
Let's try again.
Still.
How's that?
Much better. Thank you.
Okay.
Sorry about that.
No, I apologize. We're back on track. So, according to the World Health Organization, in 2022, over 40% of adults over the age of 18 were overweight, and 16% were living with obesity. But obesity rates are rising everywhere. The numbers in Latin America are especially concerning. According to the Pan American Health Organization, which is a subsidiary of the World Health Organization, over 60% of the population is overweight or obese. And in the last 3 years, it has tripled. In the last 50 years. And it's not just adults. Over 30% of children and adolescents are also affected. This is why addressing obesity early with a structured plan is so important. Healthcare systems vary widely across the region, and the goal isn't to apply a one-size-fits-all solution. It's about adapting what's worked to local settings. This graphic demonstrates the percentage range of obesity in both adult and child populations across Latin America. Notice how rates are consistently high across the region. This highlights why obesity has become such a significant public health issue in the region. How does this compare with what you're seeing in your own practices? So obesity, what is it? It's not just a cosmetic issue. It is ultimately a chronic, relapsing, and multifactorial neurobehavioral disease. This is due to an increase in body fat overall, which promotes adipose dysfunction, also known as adiposopathy. And it causes abnormal fat mass physical forces. This causes physical strain on the body. All this together results in metabolic, biomechanical, and psychosocial health consequences. I want to introduce you all to Maria. Maria is a 45-year-old woman. She has a BMI of 38. She has type 2 diabetes, hypertension, and arthritis due to joint pain. She tried several diets without any success in the past, and emotional eating is a major challenge for her. Throughout the presentation, we're going to see how the pillars of obesity care are used in her treatment. Obesity in general affects the body in two major ways. I've already touched on the adiposopathy, also known as sick fat disease. This is where the fat tissue itself becomes hormonally active and leads to issues like diabetes, hypertension, and hyperlipidemia. There is also what we call fat mass disease. And this is the biomechanical and structural aspect of the disease. The physical strain of carrying this weight causes joint pain, reflux, and sleep apnea. While telling patients to lose weight isn't enough, we have to address the metabolic and the physical effects of obesity. Maria's joint pain and hypertension reflect the effects of both the fat mass and sick fat disease. Adiposopathy has several consequences due to dysfunction of the fatty tissues. For one, it causes insulin resistance. Excess fat disrupts normal insulin signaling. This results in type 2 diabetes, fatty liver disease, and an increase in cardiovascular risk. Also, there is leptin resistance. So normally, leptin levels should reduce hunger, but due to the dysfunction of the fat, there is resistance to this, which means that there are fewer satiety signals. And finally, there's increased inflammation. Adipose tissue becomes pro-inflammatory. Elevated TNF-alpha, IL-6, and CRP, they contribute to insulin resistance and vascular dysfunction. Maria's type 2 diabetes and difficulty controlling her hunger reflect both the insulin and leptin resistances. Metabolic dysfunction is driving her disease. BMI is a good starting point, but it doesn't tell the whole story. Other measures like waist circumference, waist to hip ratio, and body fat percentages give us a more accurate picture of metabolic risk. For example, a patient who has a BMI 27 with a high waist circumference may have a greater metabolic risk than somebody with a BMI 30 and a smaller waist circumference. Maria has a BMI of 38, but her waist circumference is 102 centimeters, which confirms central obesity and increased cardiovascular risk. This brings us to the core of the talk today, the pillars of obesity care. Effective obesity care requires a team approach. Primary care doctors, dietitians, psychologists, exercise specialists, and bariatric surgeons all play a role in obesity care. Each pillar, nutrition, exercise, mental health, medication, and surgery, addresses a different aspect of the disease. And in the following slides, we're going to break them all down. So the first pillar that we're going to talk about is nutrition. Nutrition is the cornerstone of obesity management. We know that calorie restriction works, but the key is individualizing strategies for each patient. What works for one may not work for another. And the ultimate goal is to have a diet that is safe, effective, and sustainable for patients. In Latin America, many traditional diets are already nutrient-rich. You have a lot of beans, whole grains, fresh produce, and lean meats. Encouraging small changes can make a big impact in people's lives. For example, eliminating energy-dense foods and drinks like juices and sodas can make a big impact. Eliminating ultra-processed foods like snack foods and ultra-processed meats like deli meats. Even something as small as learning how to read a nutrition fact label can make big impacts. This makes the plan more realistic and sustainable for patients. I want to just touch on some of the more popular dietary patterns that we are prescribing for our patients. Mediterranean diet is one in which olive oil is emphasized as the major fat. There's an emphasis on lean meats and whole foods, such as fresh fruits and vegetables, and legumes, and again, limiting ultra-processed foods. The DASH diet, which was originally formulated for patients with hypertension, aims to limit sodium, total fat, and cholesterol, and avoiding sugary foods and drinks, as well as alcohol. Keto is another popular dietary pattern, which essentially, again, aims to avoid ultra-processed foods and to severely limit the amount of carbohydrates that are consumed, which leads to a state of ketosis and fat burning. Popular patterns like these are effective because they emphasize whole foods, healthy fat, and lean proteins, the part of any balanced diet. Other options like low carbohydrate and very low carbohydrate and very low calorie diets can work for certain patients, but these diets need to be carefully monitored by a physician or dietitian. The key is to find an approach that the patient can stick to long term. Maria has tried multiple diets in the past without much success, but that's because it hasn't been tailored to her metabolic profile. Switching her to a Mediterranean-style diet with an emphasis on lean proteins and healthy fats can help improve her insulin sensitivity and hunger regulation. The next pillar we're going to talk about is exercise. Exercise isn't just about weight loss. It can help improve insulin sensitivity, improve mood, and overall health. The Journal of the American Medical Association in 2018 put out guidelines for healthy amounts of exercise. The primary recommendation is anywhere from 150 to 300 minutes of moderate intensity aerobic exercise. You might be asking yourself, what does moderate intensity mean? So this is kind of a subjective measure, but the usual measure that we use is 220 minus age. That is going to give you maximum heart rate. You're aiming for anywhere between 60 to 70% of maximum heart rate. This can also be replaced by 75 to 150 minutes of vigorous intensity aerobic exercise, amping that up even a little bit further. They also recommend that 2 days per week of the exercise should be resistance training to help preserve lean muscle mass. The American College of Sports Medicine echoes the recommendations of the Journal of American Medical Association with very similar recommendations, but they quote that over 250 minutes of exercise per week is necessary for clinically significant weight loss. Not every patient has access to a gym, and that's okay. In Latin America and other countries, community-based options like walking groups or soccer leagues, even dance classes are effective and culturally appropriate. But before we can do any of that, we need to ensure that our patients are even able to begin exercise in the first place. Maybe it's been a very long time. Maybe they've never exercised before. We want to make sure they're going to be able to start safely. Some providers even advocate for an exercise prescription. This is one of the more popular ones called the FIT prescription, which prescribes the frequency, intensity, time, and type of exercise. And as we know, patients who enjoy what they do are more likely to repeat doing it. We want to encourage patients to start with small, achievable goals. Even an extra 10 minutes of walking per day can add up over time. The goal is to have consistency, not perfection, okay? Maria's joint pain limits her ability to engage in high-impact exercise. How many of you have heard that before? But starting with low-impact activities such as swimming or cycling can help to improve insulin sensitivity and reduce inflammation. The next pillar that we're going to talk about is mental health. One of the tenets of mental health is behavioral modification, and this begins with modalities like motivational interviewing and cognitive behavioral therapy, which are highly effective in this sphere. Motivational questioning can involve open-ended questions like, what's been getting in the way of your weight loss? What's worked for you in the past? Through therapy, we need to understand the patient's perspectives. How do they perceive themselves? How has trauma contributed to their condition? As part of this, we want to explore trends in their habits. What are some eating behaviors that they are exhibiting? What barriers do they have to physical activity? We want to touch on previous attempts at weight loss. What's been successful? What has failed, and why? Some behavioral techniques like goal setting, stimulus control, and addressing thought patterns can be especially helpful. Many patients get into an emotional eating or negative thought patterns about their self-image, and addressing these and tackling them head-on can be very helpful for patients. Even brief conversations can help patients feel supported and more motivated. It's been shown that regular check-ins with a psychologist or behavioral health specialist can help prevent relapse and reinforce positive habits overall. Care has to be accessible and consistent. Successes have to be trackable. We have to be able to keep records. And patients need to feel like they're stakeholders in their journey, not just being subjected to these things. People experiencing mental illness have a 2 to 3 times increased risk of obesity. This is a staggering number. It's important to assess patients for underlying psychiatric conditions, including mood disorders, eating disorders, and medication side effects. Many psychiatric medications can cause weight gain, so we need to clinically evaluate these and adjust them in order to prevent these side effects or add weight-neutral options. Ultimately, a collaborative approach with your mental health professionals is going to ensure that patients receive well-rounded care. While emotional and psychological factors are important, there's another critical piece that we can't overlook: the role of eating disorders and obesity. To begin with, we have binge eating disorder. This includes recurrent episodes of eating large quantities of food. Up to 30% of bariatric patients suffer from this, so it's very important to assess. Night eating syndrome is one that you may not have heard of. This involves consuming more than 25% of one's daily calories after the dinner meal. Patients even sometimes awaken during the night to eat. And then finally, emotional eating is very common. This is when patients are using food as a coping mechanism to deal with stressors in their life or previous trauma. Cognitive behavioral therapy has been shown to help break the cycle here. How often do you all see patients struggling with binge eating or emotional eating in your practices? Maria reports emotional eating when she's stressed out, which is common among patients with obesity. Behavioral strategies like stimulus control, cognitive restructuring, and goal setting can help to address this pattern. The next pillar we're going to talk about is medicine. So medicine is valuable. It's a tool, though. It is not a cure. Medicine works best when done with lifestyle changes such as diet and exercise and behavioral therapy. Indications for pharmacological therapy include a BMI over 30 or a BMI over 27 with a weight-related comorbidity such as diabetes or hypertension. An important guideline to remember is that if patients haven't lost at least 5% of their body weight in 12 to 16 weeks at maximum dosing, then they're considered a non-responder and they should cease that medication. It's also important to remember that medications are chronic. Patients are going to regain weight if they discontinue the medications. Let's take a look at some of the available options. Here we start with the appetite suppressants. These work primarily as sympathomimetics, which increase satiety and reduce hunger signals overall. Phentermine is one of the oldest medications on the market. It's approved for no more than 3 months of use, but it can be used off-label a little bit longer than that. It's safe for use in pediatrics over the age of 16, and it can afford a modest weight loss of 6 to 8%. Phentermine does require monitoring for side effects like tachycardia and insomnia. The addition of topiramate makes the medication Qsymia. Topiramate is a GABA receptor modulator. Phentermine in general should not be used in patients with hyperthyroidism or glaucoma, uncontrolled hypertension, or coronary artery disease due to its sympathomimetic effects. Qsymia, because of the GABA receptor modulator, should not be used in pregnant patients because of teratogenic effects, patients with a history of seizure disorder, patients using MAOIs, or patients who have recently stopped using benzodiazepines or alcohol. Other options include Contrave and metformin. Contrave, which is a combination of naltrexone and bupropion, is an opioid antagonist and a dopamine norepinephrine receptor inhibitor. This helps patients to deal with some of the food addiction or dependence side of obesity. It acts on the neural weight loss mechanisms, and it can afford anywhere from a 5 to 10% weight loss. This medication should be avoided in patients with bulimia or anorexia because of an increased risk of seizures, and it should also be avoided in patients with pre-existing seizure disorders or those taking opioids, as it may put them into a withdrawal. Metformin is another option. It's an insulin sensitizer and can help to decrease caloric intake. It's safe in pediatric patients over the age of 10 years old, and it can give a modest weight loss of 3 to 5%. Access to some of these medications, including GLP-1s, which I will get to on the next few slides, may be limited in some parts of Latin America or other countries. But metformin and orlistat, which is a lipase inhibitor with about a 3 to 5% weight loss, might be more widely available. Some of you out in the audience may have heard of some of these medications. They're the hot topic of today. So these are the GLP-1s, or glucagon-like receptor agonists. It started off as medications for diabetes management, and weight loss was a positive side effect, so they have become very popular for that effect. Liraglutide is a medication that is with weekly titration and daily dosing and can give up to an 8% average weight loss. Semaglutide, or Wegovy, is a monthly titration with a weekly injection, and it can give up to a 15% average weight loss. And the newest one on the market is tirzepatide, or Zepbound, which has added the addition of a GIP receptor agonist. This, again, similar to semaglutide, is a monthly titration with weekly dosing, and it can give up to 21% average weight loss in some studies. Let's talk a little bit more about the GLPs. So they mimic the hormone that regulates hunger and satiety, an incretin secreted by the gut, or GLP-1. This helps to increase insulin secretion, which helps to drive glucose into cells, and it decreases glucagon secretion. The major way by which these medications work is actually to delay the gastric emptying. This is where the weight loss piece comes in. By delaying the gastric emptying, patients feel fuller faster. So by increasing that satiety, it reduces their appetite. And as such, they are not eating as much and they're losing the weight. Apart from its weight loss outcomes, these medications actually also improve metabolic health beyond the weight loss. This includes an A1C reduction of anywhere from 1 to 2.5% in some studies. And according to the SELECT trial, can actually afford a decrease in major adverse cardiovascular events by 20%. That is huge. If access is difficult in some countries, Novo Nordisk and Eli Lilly, the producers of these medications, have patient support programs in certain countries. Contraindications to GLP-1s include pregnancy, a personal or family history of medullary thyroid cancer, and a family history of multiple endocrine neoplasia 2. This is because it has shown in laboratory studies to form de novo thyroid tumors. Relative contraindications include a history of pancreatitis, as these medications can cause pancreatitis, and a history of diabetic retinopathy, as these medications can worsen diabetic retinopathy. Given Maria's metabolic dysfunction and binge eating, a GLP-1 receptor agonist like semaglutide would help address both the hunger signals and the metabolic issues together. Last but certainly not least is surgery. So surgery is also a tool, not a cure. Okay, surgery remains the most effective long-term treatment for severe obesity. Recent published guidelines by the ASMBS, or the American Society of Metabolic and Bariatric Surgery, includes patients with a BMI over 40 or those with a BMI over 27.5 in Asian populations, a BMI over 30 with type 2 diabetes or other weight-related comorbidities, or a BMI over 30 in patients who have had demonstrated non-surgical weight loss attempts without durable weight loss. If surgical options are limited locally, focusing on maximizing pharmacotherapy and lifestyle changes is critical, and partnering with regional specialists can help to improve access. The future is combination therapy. As I've talked about, surgery, medication, and behavioral strategies all work better together. Patients undergoing bariatric surgery require an extensive preoperative evaluation, including lab testing and consultations with their specific dietitians, mental health specialists, and educators. At least as far as these preoperative preparations go in the United States, patients are required to see a nutritionist and a mental health specialist to obtain clearance prior to surgery. This is to help to understand any underlying psychological or psychiatric disorders, make sure that the patient is able to consent to the procedure, and that they understand the lifestyle changes that they're going to need. And education is key. Patients undergo extensive education with seminars and support groups and preoperative planning before they even hit the operating room. For most patients, this kind of team-based approach leads to better long-term outcomes. So let's talk a little bit more about the specific types of surgery. These graphics show the most common procedures that we perform in the United States. Starting on the left, we have the Roux-en-Y gastric bypass. This works both as a metabolic surgery and a restrictive surgery. The stomach is formed into a small pouch about the size of an egg, and the intestines are rerouted to bypass that first part of the small intestine, the duodenum. By bypassing that, we've actually induced metabolic changes that can help to cure diabetes and improve other weight-related comorbidities. The center here shows the sleeve gastrectomy, which works as both metabolic and bariatric surgery. So this is involves removing about 70% of the stomach, which includes the hunger-causing cells that secrete ghrelin in the fundus of the stomach. So by doing that, we've reduced the hunger signal, and we've also reduced the amount that patients can eat. And finally, we have the biliopancreatic diversion, or the duodenal switch. You can think of this kind of as a combination of the two surgeries. We do have the benefit of restriction and decreased hunger with a sleeve gastrectomy, followed by a duodenal-ileal anastomosis. So by bypassing a much longer portion of the intestine, we are inducing a level of malabsorption. And we're going to talk about some of the consequences in the next slide. But understanding the anatomical changes involved with these surgeries can help patients make informed decisions about what they feel comfortable with going forward with surgery. Selecting the right procedure for patients depends on various patient factors. For example, the Roux-en-Y gastric bypass can lead to a greater improvement of metabolic disease with resolution of comorbidities such as type 2 diabetes and GERD, but it does increase the risk of malabsorptive complications, which necessitates vitamin supplementation for life. Dumping can also be an issue. Dumping syndrome is where if the small intestine sees a very large carbohydrate load, then the rapid secretion of insulin can cause changes, including sweating, hypotension, and overall making the patient feel rather sick. And this can induce nausea, vomiting, and diarrhea. The bypass, however, can give anywhere from 60 to 75% weight loss. So compare these to the medications. The sleeve gastrectomy can give anywhere from 50 to 70% weight loss. This can give excellent weight loss, but it can worsen GERD in a pre-existing reflux patients. It can also cause de novo GERD in up to 40% of patients. Similarly, if patients are being seen and followed for Barrett's esophagus, this is not a recommended procedure because it can worsen the Barrett's. One of the advantages of this surgery is that there are no long-term vitamins needed. Finally, the biliopancreatic diversion duodenal switch can give anywhere from 70 to 80% weight loss, which is fantastic, especially for those patients with higher BMIs. This also gives the highest resolution of comorbidities, so it is the most metabolic of all of the surgeries. However, because of the bypass of such a large amount of intestines, this increases the risk of macro and micronutrient deficiencies, which requires frequent lab checks and vitamins for life, including fat-soluble vitamins. If Maria doesn't reach her weight loss goals with medication and behavioral therapy, then bariatric surgery would be the next step. In her particular case, a gastric bypass would probably provide the greatest metabolic benefit because of her diabetes. but a sleeve gastrectomy might be more accessible and slightly lower risk for her. So obesity is complex, and care needs to be complex too. It's a chronic disease, and it needs to be treated as such. We want to use the 5 pillars. So nutrition, exercise, mental health, medication, and surgery. And early intervention changes lives. So I implore you, start tomorrow. Find 3 patients in your practice with obesity and start the conversation. And then connect them to the right resources. You all are the first line of defense against obesity in your communities, and your impact matters. These are my references. Thank you all for your attention.
Thank you so much for recapping such an incredibly important nowadays topic, which is obesity. In public health, we always look at this condition as one of the most challenging, especially in our country, and now growing epidemic somewhat in many other countries that traditionally have never seen an increase in obesity. You reminded me particularly, and I'm sure many of our peers online, that this is something that we all need to look at it in a very, very detailed way, especially when we are confronted with these patients in these particular conditions. It is alarming to me as a public health person as well to hear you say that 43% of the adults age 18 and even under are considered obese or overweight, and 16% of these individuals live with obesity. That is quite an alarming percentage, given the fact that we are in a way in control of this particular condition somewhat, somehow, and we need some guidance on that. The other thing that I wanted to highlight is the fact that you mentioned that obviously diet and exercise is key and imperative thing to a conversation, a difficult conversation to be had, especially with those that have already crossed the threshold of what adequate weight should be. And yet, I don't think we have done a good job as a society overall in managing expectations for these patients. The fact of the matter is that we're constantly feeding ourselves with news that something might be appropriate or looks appropriate for us to consume. And we have forgotten about the basis in nutrition. Having said that, the challenge that you guys have, especially you as a surgeon, is determining exactly the direction that a patient should be taken in order for him or her to take control of her life. I love the fact, Dr. Motola, that you mentioned the 5 pillars in managing obesity. These were perhaps isolated or silos in the past, 10, 15 years ago. We never talked about interdisciplinary approach to this. Either a patient will go to a nutritionist and find him or herself in a revolving door. I mean, what is it that you're telling me that I need to eat? And now, obviously, coming to a consult where the patient gets multi-directional information, that everybody is going in the same direction, tackling the same problem, especially from mental health, encouraging exercise, and leaving medication and surgery as a last option, and talking about nutrition and exercise, it's absolutely a phenomenally imperative thing for us. Now, Dr. Motola, from the medications that you mentioned, especially the GLP-1 medications that are so common now, everybody wants to use them. Even the young ladies that feel that they have 10, 15 pounds overweight, they want to use them. I guess in a way, it opened the door for everybody to see some light at the end of the tunnel in regards to obesity. What is your sentiment in regards to the way we're using these medications nowadays?
That's an excellent point. I agree with you entirely. The dawn of these medications has kind of almost made popular the idea of weight loss because it is so easy now, right, for people. But I think that ease of use is being used as a bit of a crutch. Maybe that people have somewhat of a misplaced idea of how these medications fit into a lifestyle. Because at the end of the day, what we're going for, right, is we want people to lead a healthy lifestyle. So are these medications being abused? Yeah, you can say that. But by kind of bringing to the popular mind how these medications can be used, I think it's almost, it's helping to destigmatize the weight loss kind of picture that I think society has held on to for so long.
Right, and to that point, we also saw at the beginning of the year, if you recall, the announcement that finally the obesity epidemic or the obesity curve started to decline, which was in a way, I mean, finally a welcome knowledge that at least we have something that we can use to combat this particular issue. And yet we still do not know the side effects or the potential issues that these medications will actually bring to our conversations. Do you feel that we might be encountering some challenges with these medications in the future as side effects that are not necessarily the pleasant ones, which is weight loss?
Right. I mean, I'm sure, you've heard in the news where people are suffering from permanent gastroparesis or bowel obstructions, even perforations as a result of these medications. They're not perfect. No medication is. So I think an over-reliance should be kind of cautioned for these medications. And to your point, we don't have really long-term data. We know that it works, right? It's efficacious, and that it does have some side effects, but, we don't have patients on these meds, 5-10 years. We don't know what that really looks like. So I'm cautiously optimistic about the medications.
Mm-hmm. Yeah, similarly with those medications that were in combination in the past that got us in so many deep conversations and trouble with with the FDA and had to be retrieved from the market simply because they were overused. And of course, you still use them off-label when need be, but it is under your supervision. Physicians need to be in control of these medications and stipulate that the patient must be in control as well in order for them to know when to stop it. There is so much work to be done in this, but I love the fact that you mentioned two components that we traditionally don't see in our practices, which is the mental health component, and talk about nutrition and meeting with a specialist that has only knowledge about nutrition. We have a myriad of diets. We're constantly bombarded with diets and diet products, and yet we don't necessarily stop to reflect if they are good or bad or detrimental to our health. And only a person that understands nutrition can actually facilitate this type of conversation. I love your fit exercise prescription. I think that every person that is already labeled as that has the opportunity to improve their health needs to hear this, which is the frequency, intensity, time spent. I had to take notes, type, and it is just an incredibly important thing to push for patients. And I think that the message should also be not only relevant for the patient and the practitioner, but it needs to be placed in the hands of the patient saying, You have it in your hand to actually fix this problem. This is one way of actually doing it instead of actually doing medications and surgical procedures. Any last thoughts, Dr. Motola, that you are excited about for the future, either in medications or procedures that you consider that we should be looking into? I love the fact that you're a surgeon and specialize in bariatric surgery, and yet you rely on all these incredibly wonderful techniques to help our patients.
Yeah, I mean, I just wanted to touch on something that you had mentioned about mental health, right? I think that it's under utilized. You know, a lot of these patients have some underlying mental health issue. Almost 50% of patients undergoing bariatric surgery have some underlying history of psychiatric issue.
Right.
And we harp on to our patients, we harp on the fact that most of the work is right here, right? It's about changing your mindset and your relationship with food. You can't just rely on nutrition. You can't just rely on exercise, right? You can't out-exercise a bad diet and vice versa. So it's really about changing behaviors and changing the mindset. So more than anything, I think that connecting patients to mental health care, or even taking it upon yourself as a primary care doctor to even do some short amount of motivational interviewing to see what the reasons are, you know, really dig into it, because most people don't dig into it, right? But even that little bit of effort can reveal a lot. As far as, you know, what the future of obesity care looks like, I'm really hoping that, you know, the medications continue to be sustainable. They keep coming out with stuff. I was having a conversation with one of my physician assistants today that, heck, maybe in the next 5 to 10 years, you're going to be hearing about the new gut microbiome treatment that is going to help treat obesity, or the new, you know, enteral nervous system stimulator that's going to help treat obesity. There's so much that we still don't understand about the disease. We're just barely scratching the surface as far as we know about the inflammatory effects that I mentioned previously. But I think that it's a very exciting field. Certainly in the field of the surgeries, people are getting more and more interested in endovascular and endosurgical options, endosurgical options such as duodeноmucosal resurfacing and these sorts of treatments that are more metabolic than anything. Very exciting stuff.
I'm sure it is, Doctor, and I love your definition of obesity when you stated that there was a chronic relapsing multifactorial and neurobehavioral disease, and this alone should all give us a pause that obesity comes in many ways, shape, or form, no pun intended, but we really need to take a look from multiple angles and understand this particular condition. Look, I am going to let you go because I know that you're busy for the rest of the afternoon. I am so thankful that you accepted our invitation. And once again, welcome to our team. We're really excited to have you. And to everybody that participated today, thank you so much for attending and for listening to our good doctor here. If you have additional questions or you're concerned about your own weight or your specific patient that requires intervention or requires some kind of an assistant, please don't hesitate to send them to us. Our email is BHIWebinars@baptisthealth.net, BHIWebinars@baptisthealth.net. We look forward to seeing all of you at our next surgical lecture series, which is scheduled for September 24th, 2025. Thank you once again, and great afternoon to everybody. Thank you, Dr. Motola. Have a great evening.
Thank you all. Thank you.
Bye. Thank you.